organization is physician-led, and thanks for taking a look at what it is that the Pennsylvania Clinical Network is all about. In order to begin our discussion, I'd like to talk about the notion of value-based care. It makes no difference if you're on the right side of the political spectrum or on the left side of the political spectrum. Everyone on both sides and everyone in the middle, including the insurers who are in the middle, agree on one thing, and that is value-based care is an important aspect of future health care reform. Value-based care, or VBC for short, is any healthcare delivery model in which providers, including hospitals and physicians, are paid on the basis of patient health outcomes. This is otherwise known as the transition from volume to value, quote unquote. Volume being characterized by the fee-for-service reimbursement system, and value-based care, value being reimbursed to physicians in a completely different approach of care. How's this working out in the marketplace as value-based care continues to grow? Well, what we're beginning to see are headlines like this from the Wall Street Journal. Behind your rising healthcare bills, secret hospital deals that squelch competition. As large integrated and other hospital-based systems pursue value-based care, in some areas of the country, what we're seeing are deals that are to the disadvantage of the healthcare consumer. This is being accompanied by other headlines. For example, this article from Forbes that points out that hospital CEOs are behaving badly. How does this actually work? Well, unless physicians in a physician network, in a hospital network, cooperate, they could be threatened by, for example, lack of referrals, the prospect of having competing clinics set up across the street or next door, and the withdrawal of administrative support, such as medical directorships or support in emergency room or other access to system level care within these delivery systems. We're also seeing non-compete insurer deals. For example, closed networks that, as everyone knows, can result in unpleasant surprise billing for healthcare consumers. And some large health systems are even pursuing their own health plans on an ASO basis that include tiering and exclusions and all the other things that go into versions of healthcare that are not to the advantage of the patients that we take care of. There's another way to look at this, however, and that has to do with revenue mix. As we know, healthcare costs are going up year after year after year, described as healthcare cost inflation. Sometimes it might only go up 1%, other years it goes up as high as 10%, but healthcare costs, how we pay ourselves, how we pay our team members, rent, mortgage, medical equipment, everything else that goes into the delivery of healthcare systems continues its inevitable march upward. Year after year, it used to be that fee-for-service income, or the volume base of the ledger, did a good job of keeping up with overall healthcare costs, but not any longer. Fee-for-service fee schedules are going up slowly, but they're not keeping up with the cost of running a clinical practice. Instead, what we're seeing is that this blunted rise in fee-for-service income is being used to help underwrite the cost of the transition to value-based care. So between the twin income streams of value-based care and fee-for-service care, overall healthcare costs are being met by physicians, but that means that physicians need to not only manage their fee-for-service income carefully, but they also need to do everything they can to maximize their value-based income. If they don't succeed on both sides, they run the risk of being put out of business. We've talked to physicians across the state about this, and our message has resonated. To date, we have relationships with 58 independent clinics with 168 providers, physicians, and advanced practice clinicians who have given us signatory authority to negotiate with insurance companies across Pennsylvania on the topic of value-based care arrangements. 46 of our clinics are primary care with 120 physicians and advanced practice clinicians. Our message has also resonated with the insurers who agree that we provide an important alternative in the healthcare marketplace. We have just under 25,000 covered lives in 6 insurer contracts, all of which have been powered by the Pennsylvania Medical Society. Because we're a statewide organization, the patients that we take care of by payer class are not evenly distributed. Depending on what area of the country you are in, you might see more patients in one payer versus another, but our approach to all of these payers is exactly the same. We want to do everything we can to increase value, increase quality, manage utilization, and improve the patient experience of care. This has captured the attention of not only some of the press releases that we've generated, but there are reports out there that look at physician organizations and the footprint that they are creating in the healthcare marketplace. This is one report looking at Central Pennsylvania that points out that the PA Clinical Network is as big as and stands side by side with some of the household names that we're familiar with here in Central Pennsylvania. The same is true in other parts of the state. As the report notes, that the Pennsylvania Clinical Network is seeking to provide Harrisburg's independent physicians who are looking to embrace value with an alternative to the market's large health system-owned clinically integrated networks. We have our own clinically integrated network formed by the Pennsylvania Medical Society. The quote from the report that I've outlined for you in blue at the bottom of the slide is important. The market's remaining independent physicians have formed their own network to pursue patient innovation, though these providers and other providers across the state and nationwide will continue to feel pressure to align more closely with one or more health systems as these large health systems continue to grow. So what is it that we're doing? Why are we succeeding? Well, we have three approaches. The first is that we count on our physicians to manage care. They're doing a good job. We want to help them do an even better job. We do it through a better system of care, and at the same time, we're leveraging technology. Let me talk a little bit about the physicians. Well, what's in it for the docs? Well, they get 70% of the upside. Whenever we negotiate a contract, we want our physicians to get 70% of the benefit, 70% of the income associated with that. That stands in contrast to what we're seeing in the marketplace, where 50-50, 40-60 splits are common. We're the Pennsylvania Medical Society. We think physicians should get the lion's share of the upside reward. We also count on our physicians to help us with running the enterprise, governance, participation. We have a number of committees that deal with key topics such as credentialing, quality, funds flow, contracts, and we ask our doctors to participate. As a matter of fact, we value it so much that we ask our doctors to also accept payment for their time, because it takes time and effort to be able to make our committees work as well as they do. However, there's still skin in the game. This isn't for free, and we ask our physicians to help pay for the information technology that's core to our success. All of this has been working great, the latest example being the COVID pandemic. We have found that all of our physicians not only survived, but thrived a little bit as a result of the transition to telehealth and being able to provide in-person care for patients who needed it in their practice sites. Our Pennsylvania Medical Society brand has been very, very important to the success of the enterprise. And as I noted before, we're not interested in the survival of physician practices. We want them to thrive. The second part of our support has to do with our scaled, high-touch personnel who are traveling around the state, helping clinics close patient care gaps, enhance coding, optimize workflows, all in a spirit of shared learning. We want our physicians to get credit for the work that they're already doing. They can oftentimes do this by enhancing their coding and taking